It's really humbling to speak after John, because I think the most remarkable thing I think about John is that he believed in elimination when it was unbelievable, when there was no cure. And that really, for us, is an example of stamina and determination. Where are you, John? Where's he gone? Anyway, so thanks for that. So I will try to share with you some of the approach that we can use to use the core indicators and monitor the progress towards elimination. In 2016, at WHO, we produced a monitoring and evaluation framework made of 10 core indicators that were supposed to guide the progress towards elimination. So those start from the baseline, then they move towards the input, then the core interventions in terms of prevention, including vaccine, harm reduction, and injection safety, and then the cascade of care and cure. And then the elimination, as John has mentioned, is defined on the basis of a reduction of prevalence and mortality. So that M&E framework, I think, has stood the test of time. Most people find it relevant. But at that time, it was still a concept that needed to be applied. So we elaborated and sort of explained the kind of data system that were needed in countries for this monitoring and evaluation framework to be populated with data. So on the program side, we need prevention indicators, and we need the cascade of care and cure, but also to see how the interventions actually impact the epidemic itself in terms of incidence, prevalence, and mortality. We need good hepatitis surveillance. And that has been summarized in this sort of aide-memoire. And next to Michael at the back of the room, I've brought a few copies of these one-pager if you want to grab some on the way to the coffee break. So in order to try to answer the question that was asked by the organizer of the meeting, I will try to walk you through three questions that we're sort of asking ourselves at this stage. The first one is, how well are we implementing prevention, testing, and treatment? How does our monitoring framework actually keep track of that? Then the second is, how does this turn into progress towards elimination? And the third one is, when we sit in WHO headquarters, regional, and country office, what can we do to help the member state to actually have a grasp on their epidemic and the intervention, and how can we empower them to use the data that will actually drive the program decision? So the first point, how well are we implementing prevention, testing, and treatment? So first, in terms of prevention indicators, we don't need to reinvent the wheel. I think John has made a case that prevention has moved forward considerably, whether it's vaccination, whether it's the birth dose, and I think last week there was a major step forward announced by Gavi in terms of support of the birth dose, in terms of blood safety, in terms of injection safety, and in terms of harm reduction. So for all these core interventions, there's actually a data system that's already in place to funnel data back to countries and to WHO, and we don't have to duplicate that. We just have to work with these people and centralize that data. So the big piece for which we really need something new is basically the cascade of care for B or cure for C. Now, I'm going to get a little bit technical here, talking a little bit about data management, but I think it's worth 2 minutes of your attention. A lot of people, particularly if we're a clinician by background, like it's my case, we like what's on the right, the medical records that would be turned into electronic records, right? Because it's all individual records. It can be sourced in real time through electronic medical records. But that approach can be actually quite heavy in data entry and management. And it's more complex to analyze. But out of that, we get some deduplication if we have unique identifiers, so we know who is who, and we can cross-tabulate. So it's definitely a nice way to build a cascade, but it's one that may be not affordable to keep track of all these people we want to put on treatment before 2020. So the other tool that we have in our arsenal is to work with aggregated data. So we're not talking medical records anymore, we're counting counts. So in terms of data volume, it's much less. Okay? So these would be counts of person receiving services that we can source in tally sheets or in registers. So it's really much more efficient. You get 80% of the benefit with maybe 5% of the investment. It's very easy to analyze. You just have to make some additions. Unfortunately, it doesn't allow deduplication and doesn't allow cross-tabulation. So I will be back to these notions later, but I think if we really want to take the M&E of the elimination to the next level, we need to be a little conversant with these technical aspects and base our M&E system, our cascade monitoring system, on a portfolio of these two approaches, aiming at something that's efficient. So when we started work on how to make it happen, we really worked hard and we consulted with a lot of people so that what we call our reporting requirement would actually be simplified to the bare bones and would be the same from the healthcare facility to the district to the Ministry of Health all the way to WHO at the regional level and in Geneva. So this is where we get at. We want to keep track of 4 areas: testing and diagnosis, treatment initiation and continuation, monitoring of treatment effectiveness, and the mortality from sequelae. So you can count, we have 20 data points. It's really boiled down to the minimum. And if we organize our registers in the healthcare facility, whether they're on paper or electronic, and the data transmission along those lines, then we have everything we need to monitor the progress of the cascade and to build these graphs that we like. So now the question is, how does this turn into progress towards elimination and disease reduction? So I don't know if you're familiar with this analogy, and that's one I really like to use to talk about hepatitis surveillance. You know the blind people that are trying to identify what an elephant is? So the one touching the trunk says it's this long thing with a hole in the middle. The one in the middle says, oh, it's a very flat thing. And the one in the tail says it's a very, hairy piece. So I think it's very much a good metaphor to describe how, as epidemiologists, we can actually understand a hepatitis epidemic, because it's something that unfolds over more than 30 years. So you have outbreaks, for instance, that are like very mature, like in France or in Japan or in Italy, where transmission happened after the Second World War, and that transmission has been put under control, and now we're almost past the wave in terms of mortality. But you have expanding outbreaks still on the level of incidence, like Pakistan, where the burden in terms of mortality is still rising and the wave is still going up. So with hepatitis surveillance, it's nice to have model, but it's also important to try to capture some of these data points with surveillance all the way from incidence to prevalence to mortality, so that we can actually try to have a good idea of how this unfolds over time. So the tripod of hepatitis surveillance is one that looks at these 3 aspects. The number one, that's probably the most important, and if you remember, it's a core indicator number 1, is the prevalence. We need to obtain reliable population-based estimates of prevalence of infection, if possible by age. And that's really the starting point to find out the importance of the problem. Then we may want to find out what are the incidence trends and who gets infected. And that's being done with enhanced case reporting of acute hepatitis. Those acute hepatitis are only a very small subset of the new infection, but they're one that really inform us on what's going on. In the US, for instance, they've been doing enhanced case reporting for acute hep C, and for many years it says going down, it's going down, it's going down, it's going down, and one day it's going up because of the opioid crisis. So very imperfect surveillance system, but one that can really tell you what's happening. And the last one is capturing mortality, and to go back to Amir's question to why was this underestimated, I think one of my explanations is that it's so difficult to measure because you have to match the data from cirrhosis and HCC mortality and the data on the atrial fraction. And it's not rocket science, but it takes a little bit of work. So we need these systems working with providers who take care of chronic liver disease, whether it's cirrhosis or HCC, and find out the proportion that come from B and C. Because when we match that with mortality records of cirrhosis and HCC, then we can have the true picture of mortality. And I'm quite happy to say that we managed to work with the new management of WHO, and that now the General Program of Work 13, the flagship of the new DG, is including that as a key impact indicator. Now, how do we help WHO member states making use of all this data to make decisions? So we have a sort of approach in 4 points that we've sort of pilot tested in a number of countries I'd like to share. Number one, we try to work with member states to look at their data system and see what is the quality of the information that's available there. Second, we also try to work with them to extract the baseline information of the 10 core indicators, really imperfect data, but some sort of working estimates on the basis of which you can plan. Then third, coordinating the reporting of the data on the cascade of cure at the national level. And last but not least, it's a bit of a self-serving agenda, but we want the data to be funneled back to the mothership at Geneva so that we can actually report back and be accountable to our member state as to whether the elimination is progressing. So here's an example of the first point. Here you can see all the elements of the data system, the surveillance for acute, chronic, and sequelae, and the program indicators, whether they're on prevention, care, and treatment. So we've worked with our country in the Eastern Mediterranean region to try to understand what information they can rely on to generate that information. You can see it's not that bad. When you start working, you actually find there is more information than you think. You just need to go and talk to the right person. I think Dr. Leshy says that. The information is there. We need to know who has it and get it out of the medical records in the hepatology ward. So that provides an initial snapshot. Here, of course, the color coding reflects the quality of the information, and that's the starting point, and we can work to improve the quality of the information. Then second, and it's a very linked exercise, we can actually do some data mining, data extraction, whatever you want to call it, and extract whatever information is available where we can find on the 10 core indicators. This is from another country in the Western Pacific region. I was there 2 weeks ago. So before I arrived, they said, we probably don't have much information. We're so sorry. But when we spend a whole week reaching out to X, Y, and Z and making phone calls and bringing people to the table, you realize there's way more than you think. And again, that's not perfect data, but that's a working estimate that you can use as a baseline. The third step is trying to organize a way to monitor the cascade of care in a country. So I'm going to go back to a few technical issues, and it's also based on a case study from a country of the Southeast Asia region where I was last week. So you can see it starts from the right-hand side and then all the level, the way to the left-hand side. So in that country, we have a bunch of providers that are actually using individual data system, but they've colored them in different way because they don't speak the same language. There's no interoperability. And there are a few providers that are only reporting aggregated number. So if you sit in the capital and have to receive that, you're receiving apple and oranges, right? It's not easy to do. So you want them, at the moment, they're reporting this aggregated number, but the data manager at the national level doesn't have the capacity to compile the information. So, and doesn't have the capacity to generate the cascade for B and for C. So we've developed a manual to assist countries with using this information in whatever forms it starts, whether it's individual data or aggregated data, and try to regress it to the reporting requirement that I mentioned earlier and put that under an overall umbrella to generate a national dashboard. So it's not rocket science. Again, it's compiling and adding numbers, but you need to have this happening in an ongoing, routine sort of a way. And having a subset of the national database managed with individual records is wonderful because in that country, for instance, I'm talking about, they have suboptimal SVR, which may be due to the fact that some patients with cirrhosis are not well identified and don't receive the full course of SOFDAC. So you can use that individual database to answer your clinical question, but the majority of the bulk can be handled with aggregated data. And we have a software called District Health Information System 2, DHIS2, that can be used to generate that dashboard. So the last point is organizing the international reporting to WHO. So we've launched the global reporting system for hepatitis in July. So every member state, every Ministry of Health of your countries have received a letter with login credential where they can enter some information on the policy uptake indicator, the cascade of care, and the sequelae. And they can access their own dashboard and find their progress. So on this picture, you can see our work with a country of the Western Pacific region, where after the data extraction exercise, we went online and we entered the data in the global reporting system. So that's the last one. So Margaret, you wanted the blood and guts and the difficulties. So here they are. So the first one, actually, and it's one it's a humbling realization, is that we really need to, as disease-specific people, to realize we need to follow the National Health Information System governance and integrate the national blueprint in order to make functional system. If we want to do something on our own, it's not going to work. And that is not the easiest thing. You really need to walk across the hallway and talk to your colleagues. We need to deliver user-friendly information technology tools that would really help program manager with dashboard they can see right away. And we need a feedback loop of information that will provide an incentive to reporting. So I'm done, and the conclusions I wanted to share with you is that we do have an M&E framework. It's conceptual, and it's definitely been accepted as a foundation to review and monitor the progress, and we need to take it to the next level. We need to set up surveillance system that will look at the 3 key stages of the outbreak, and we realize more and more that mortality is really key for impact monitoring. In terms of the program data, prevention is taken care of for the most part, but the cascade of cure is something that we now need to establish with data systems. So we need efficient, integrated national data system that can guide the national program, and we need a global system that centralizes the data from all the member states so that we can share the good and bad news as a community in practice. What are our immediate next steps for WHO? What I will be doing in 2019 with our colleagues in the country and regional offices. Number one, we want to integrate the national DHIS2 packages, the dashboard system I was telling you about, with HIV, tuberculosis, and malaria within the National Health Information System, because if we go together, we have a better chance to succeed. We're going to be working further to have the HCV treatment as a universal coverage tracer indicator. We're very close to the goal. We still have to go through a last level of review, but it's very close from acceptance, and that will be a very useful push for us to get the data from a country. We want to also provide a functional, efficient national model for data extraction reporting that we can then reporting. We hope to collaborate with Prove on this. We want to generate the incentive and momentum for a global reporting, and after the first pilot version of the reporting system from this year, we hope to have the global reporting system 2.0 up and running next year. And the last one, and last but not least, we want to understand better the pre- and post-treatment mortality trends. Remember what I was telling you about the mature outbreak, the mature epidemics, the more recent epidemics, and where we stand? I think it's very important for country to really understand where they sit in terms of that mortality wave, because when they scale up testing and treatment, they want to understand better their effect on mortality. So I'd like to thank you very much to introduce the member of the team, the Global Hepatitis Program, at least the Geneva part. And please, my humble submission, as they say in India, help us by reaching out to your national focal point with National Ministry of Health, and help us to get the data reported in the global reporting system for hepatitis. Thank you very much.